I find YouTube to be the easiest one to search, so save it for your future studies. And as always, drop those comments, drop those questions into the chat. We have Nurse Jackie moderating today. She's standing by to answer any questions that you all may have. So drop any questions, any comments, and of course, answers to today's questions into the chat. Let's go ahead and get it started by letting us know where everyone is joining from. Who's coming from the US, who is the international viewer. Let's get that chat warmed up by you guys going ahead and dropping it in so we know. I see you're now saying that the sound has been resolved, so I'm glad it is working now. Perfect timing. Let's go ahead and jump into today's content. We'll start out with hyperemesis before we move on to the hypertensive disorders. Alrighty, so we're going to move on to our hyperemesis table. Now, hyperemesis gravidarum, I feel like this is a lesser known antepartum disorder. It's the severe, prolonged, and persistent nausea and vomiting. So most women who become pregnant will typically experience some nausea and vomiting, usually in the first trimester, and we see that taper off and resolve usually around the second trimester. I think this has gotten a lot more publicity and recognition in the past few years. If you know, Princess Kate, Princess of Wales over in England, as well as the comedian Amy Schumer, they both suffered from hyperemesis gravidarum when they were pregnant. So I think this really caused some much needed attention onto this cause. So unfortunately, the exact cause of hyperemesis is still unknown. Experts believe it to be the increase in pregnancy-related hormones that are to blame for this disorder. And this is actually supported by the fact that women who are having multiples, like twins or triplets, are more likely to experience hyperemesis because they experience greater pregnancy-related hormone increases than a woman who is carrying a single gestation pregnancy. So many clients who suffer from hyperemesis will need to be admitted to the hospital at some point, at least once throughout their pregnancy, and this is due to the unpleasant symptoms that this disorder causes, which leads us right into our clinical features. So hyperemesis is characterized by a weight loss greater than or equal to 5% of pre-pregnancy weight. We see dehydration, and signs of this will be poor skin turgor, hypotension, tachycardia. We can have increased urine-specific gravity, which essentially just means concentrated urine, as well as we can see increased hematocrit, which means we have concentrated blood from this dehydration. Electrolyte imbalances can also result. We can see hypokalemia, being that low serum potassium, as well as metabolic alkalosis. Vomiting is a very common cause of alkalosis, that stomach acid, that bile that's so acidic. When you're vomiting it up and getting rid of it, you get less acidic, meaning you get more towards the alkaline side, which makes sense why we would be in metabolic alkalosis. Lastly, ketonuria. The liver helps to create energy by breaking down existing components in times when the client is not getting enough food and not getting enough nutrition. And hyperemesis, where this client is so sick and throwing up and so nauseous, they're probably not going to be able to consume or keep down a lot of food. So the liver then breaks down their existing components, which leads to the release of ketones in the blood as a byproduct of this process. And this is what leads to ketonuria. Alrighty, so nursing interventions. I see someone asking if we'll get practice questions today. We sure will if you stay tuned to the end, and I'll have a couple questions sprinkled throughout. So our nursing intervention, so the inpatients that get admitted for hyperemesis, we're really going to be focused on comfort care here. We're going to help alleviate the vomiting, relieve our nausea, replace the fluids, and correct any fluid, electrolyte, and nutritional imbalances. So how do we do that? We're going to treat with IV fluids. They may get a bolus upon coming in. We may give a banana bag down the line, and then of course keep them on a steady drip of whatever IV the provider wants them on. We're going to give antiemetics like Zofran or Phenergan, and maybe thiamine, which is vitamin B12. These clients need to be on calorie counts as well as daily weights. If they do have any resulting electrolyte imbalances like that hypokalemia, we know that this has a potential to cause cardiac disturbances like dysrhythmias. So these clients will be indicated to be on cardiac monitoring. We will closely monitoring intake and output, which includes all output, whether it's emesis or, of course, going to the restroom. We're going to check for urine ketones, and we're going to initially place them in PO for digestive rest. Once they're able to tolerate a little something, we may move up to ice chips, go from a clear liquid to a full liquid, and then gradually incorporate solids. The brat diet is a great thing when we do decide to advance the diet, with that being bananas, rice, applesauce, and toast, I believe. So fetal monitoring is indicated. These clients that are really early on gestationally will just get Dopplered for the fetal heart rate, which is just a quick just one little, you put the gel on the Doppler and you auscultate the fetal heart rate. But clients that are further along, usually 20 plus weeks, are going to get NSTs, which are non-stress tests, which checks the fetal heart rate over time, accelerations, decelerations, variability, just seeing how that baby is doing and how they're reacting to their environment. Alrighty, now the goal of any nurse, we are trying to do these interventions in the hospital so we can eventually get these clients to get to go home. So home management is going to require a lot of teaching up front so these clients know what to do and what to expect. It's mostly diet based, so we're going to educate these clients once they are sent home on the need for small and frequent meals about every 2 to 3 hours apart. We want them to avoid an empty stomach because that's going to be a trigger for nausea. Snack as soon as you get out of bed in the morning and even until you're going to bed at night. Food should really make sure they're avoiding strong odors or heavy, greasy meals, things that are spicy, have really pungent odors, fried foods, maybe like really pungent fishes. We want to make sure we're avoiding any triggers for nausea or vomiting. Clients should sit up after meals to help them digest. This will also help with acid reflux. When drinking, especially when they are a little bit nauseous, they need to make sure they're drinking lots of fluids, but taking small sips, and cold carbonated beverages like a ginger ale or a Sprite can also help to alleviate nausea. We want them to also choose the right food. So dry and high carbohydrate foods like bread and crackers are going to be a little bit more comfortable for these clients, and then cold foods are typically preferred over hot foods. I got a tip from one hyperemesis patient that I took care of, that if you were craving anything before you got nauseous or a few weeks ago before the hyperemesis really kicked up, that's what you should eat when you are able to eat. Eating the things that you crave just as a little extra tip to kind of like help keep it down. So if that's a grilled cheese, whatever that is, if you eat what you're craving, that's a little extra help to try and keep it down. Alrighty, I see that Lyme passed the UWorld NCLEX thanks to UWorld, so we're so excited to see that. We have just concluded our hyperemesis part of the lecture, and now we're going to move on to what will be the bulk of our lecture, which is the spectrum of hypertensive disorders during pregnancy. So thank you for anyone who's just joining. Alrighty. So we have a great table. We're going to move on to the table that shows all of the different hypertensive disorders that can occur during pregnancy. Again, anything that we put up here, feel free to screenshot, keep it for your own reference, take a picture, whatever works best for you. This table is a great way to follow along today's hypertensive content. So if you want to keep it pulled up after you screenshot it, that's a great idea. If you get lost, you can always jump back to the table and find your way. So let's start with gestational hypertension or hypertension of pregnancy. So this is separate from chronic hypertension because chronic hypertension, of course, was present before pregnancy. A patient with chronic hypertension will, of course, continue to have hypertension throughout pregnancy. Pregnancy is not going to magically heal it, but chronic hypertension differs from gestational hypertension because gestational hypertension, it means it's new onset at 20 or more weeks of gestation, and we have no sign of end organ damage and no protein in the area, so no proteinuria. Typically, gestational hypertension resolves after the delivery of the placenta, and there's still a lot of research to be done on gestational hypertension. Again, just like hyperemesis, we don't know the exact cause, but doctors believe it has to do with the placenta as well as the body's hormone-related changes during pregnancy. So clinical features of gestational hypertension include a blood pressure that's greater than or equal to 140/90, and this needs to be confirmed via 2 separate blood pressure measurements taken about 4 to 6 hours apart. Typically, again, there's no lab or abnormalities that accompany gestational hypertension, so we're not going to see proteinuria. And the scary thing about gestational hypertension is that many pregnant women will feel fine. They'll be asymptomatic and not realize that they're having high blood pressures. In addition to that, the other scary part about gestational hypertension is the potential for disease progression. So this can go ahead and progress to more serious things. It can progress to preeclampsia, to eclampsia, and all the way to HELLP syndrome at the worst. We'll cover this later in today's lecture, but again, just to kind of drive home the big picture, this is the spectrum of acuity that I was talking about earlier. So other complications that can result from gestational hypertension include restricted fetal growth. You may see this seen or denoted as IUGR, which means intrauterine growth restriction. A lot of times we'll say IUGR 7% or IUGR 8%, just meaning the percentile that the baby is. Placental insufficiency is another complication we can see from gestational hypertension, meaning that the placenta is not adequately supplying blood and oxygen to the baby. Placental abruption is another really scary complication of gestational hypertension. What this means essentially is that placenta cannot withstand the high blood pressures of the body, and it starts to forcibly get peeled off that uterine wall. And when this happens, it cuts off blood and oxygen supply to the baby. A key sign of placental abruption is going to be a rigid board-like abdomen. And I'm going to give you a little hint, hint, wink, wink. This is a key sign of a hallmark sign of placental abruption, and you may see it in a later question. Alrighty, I see someone saying if we can change the screen just to the hyperemesis. Thank you, Matthew. Alrighty, and we're going to move on. Also, maternal stroke is another potential complication of gestational hypertension. We can see pulmonary edema as well, and in worst cases, unfortunately, we can see maternal or fetal death from this. So definitely something to be taken very seriously. Our nursing interventions. So when it's just at an office visit, which is typically where we catch gestational hypertension initially, we're closely monitoring the client's blood pressure as well as their weights. Hypertensive disorders of pregnancy have the potential to cause really quick swelling, really quick edema. Typically, it will manifest in the hands, the face, and the feet quickly, or those are the first places that we'll see it. So we need to keep an eye on the swelling. If the weight all of a sudden jumps like 2 or 3 pounds in one day, this is a cause for concern, a cause to call your office or provider. Once a maternal client is already identified as having blood pressures, which remember, those are 2 separate measurements taken 4 to 6 hours apart, she'll then need to monitor her blood pressure consistently at home using a reliable blood pressure monitor. And she'll be educated to report any symptoms. Headache, increased swelling, blurry or spotty vision are all things we can see resulting from gestational hypertension. She'll be educated on how important it is to monitor fetal kit counts and report any decreased movement. And she should anticipate a typically early induction of labor. So now when we do admit this client for induction into the hospital, the nurse will be closely monitoring her intake and output. She'll be testing for any proteinuria, and she needs to monitor for disease progression because, as we clarified earlier, this does have the capacity to progress to preeclampsia or eclampsia. And speaking of that, we're going to go ahead and move down the acuity spectrum to preeclampsia. Alrighty, so we're on the next stage of the spectrum here. Alrighty, so things are getting a little bit more serious in preeclampsia. Again, another hypertensive disorder of pregnancy. It's diagnosed as that high blood pressure at or after 20 weeks of gestation. It includes proteinuria or signs of end organ damage. So that's what differentiates it from gestational hypertension, is that gestational hypertension was that identified blood pressure with no signs of proteinuria or end organ damage, whereas in preeclampsia, we do see that proteinuria and we can potentially see signs of end organ damage. So we see preeclampsia is a systemic vasospasm of the blood vessels caused by the placenta, and the only cure for preeclampsia is delivery of the baby and delivery of the placenta. So severe preeclampsia is definitely an indication for the baby needing to be delivered. So risk factors. Clients that are at a higher risk for developing preeclampsia are those that have chronic hypertension, those who had a prior history of preeclampsia in a prior pregnancy, those with diabetes mellitus, and multiple gestation pregnancies being twins, triplets, or so on. So there are 2 different kinds of preeclampsia. The first being preeclampsia without severe features, which is defined as, again, that blood pressure of 140/90 or greater with proteinuria. To test for this, often in a hospital setting, we'll do a 24-hour urine test. So we collect all of the urine in a 24-hour period, and we send that to a lab to get tested. On the flip side, we have preeclampsia with severe features. So this is a little bit more serious. Here we see blood pressures at or greater than 160/100, and it can damage organs at these really, really high pressures. So we can also see preeclampsia with severe features manifest as thrombocytopenia, increased creatinine. We can see those liver function tests, those increased LFTs like AST and ALTs can go up. These are essentially signifying signs of liver damage. Clients with preeclampsia with severe features can also experience visual or cerebral symptoms, things like headache, blurry vision, spotty vision. This can also be a warning sign of an impending stroke due to that high blood pressure. So potential complications here on the maternal side, things get pretty serious. We can see AKI or acute kidney injury. Again, any high blood pressure issue, kidney injury, and then diabetes always kind of go hand in hand. I know we've talked about that triad before, but just always something important to keep in mind. Clients can also experience pulmonary edema. We can see the potential for ischemic stroke from these really high blood pressures, the potential for liver failure or even liver rupture. DIC is also a potential complication here that stands for disseminated intravascular coagulation and its problems with clotting functions. And preeclampsia in the maternal client can eventually progress to eclampsia, which just means eclampsia means seizure. So preeclampsia is pre-seizure. They can progress to eclampsia, being that the client starts to seize. Complications in the fetal client are mostly caused by just not getting enough blood flow and oxygen through the placenta, and this can cause placental abruption, restricted fetal growth, that IUGR that we talked about a few minutes ago. We can see preterm birth and, unfortunately, fetal demise. So again, very, very dangerous. Our nursing interventions, the only real cure for preeclampsia is delivery of the fetus and the placenta. Our nursing interventions will mostly revolve around preparing mom for birth because, again, there's no cure. We're just monitoring and preparing the mom for birth. So hourly intake and output is going to be really, really important. These preeclamptic clients have a huge potential for holding on to water weight, really quick and severe swelling and edema. We want to check their refluxes, and we're really kind of checking on both sides of the spectrum here. So brisk refluxes are a really great indicator of an impending seizure. So those brisk DTRs are going to be a sign that a seizure could be coming. We want to make sure we're administering antihypertensives in the meantime to control and bring down high blood pressures and prevent strokes. Labetalol is a really common one that we would give in the hospital, which can be given IV or it can be given oral. Seizure prophylaxis is also really important. Again, preeclampsia means pre-seizure, eclampsia is seizure activity. So we want to make sure seizure prophylaxis, we're patting the side rails of the bed, removing anything that if the mom were to seize that could injure or damage her. We also most likely are going to start this mom on a magnesium sulfate drip. So this requires really close assessment. Magnesium helps the mom, it prevents seizure, it's seizure prophylaxis, but it's a high alert drug. It requires a lot of close assessment and close monitoring to prevent magnesium toxicity. So a sign of magnesium toxicity can include slow refluxes. So on one side, we are making sure that we're not having brisk refluxes, which is a sign of an impending stroke. On the other side, we also want to make sure that these aren't depressed refluxes, which are a potential sign of magnesium toxicity. So other side effects of this MAG can include feeling flushed, feeling hot, some visual disturbances. They may feel really sweaty. We're going to closely monitor intake and output. Most of these moms are going to be have a Foley. They're also going to monitor for headache and blurry vision, making sure her blood pressure is staying within parameters. And in most cases, the maternal client will stay on a magnesium drip until 24 hours post-delivery. So you're in it for the long term when you have to be on a mag drip. Depending on the gestational age of the fetus, if it's not delivered yet, we're also going to do a couple of things. So betamethasone, this is a steroid, and it's going to be something we give to help develop those fetal lungs. So in a fetal client, the very last thing to develop are those lungs. This beta kind of helps to get it over the edge. So when we deliver them, those lungs are as strong as they can be and as independent and able to breathe on their own as we can potentially get them. This is given via 2 IM or intramuscular shots to the maternal clients. We try to give these 24 hours apart, but if the preeclampsia progresses too quickly, we're not always able to wait a full 24 hours to give the next one before we're delivering the client. Alrighty, so let's revisit back to where we are on the hypertensive disorders of pregnancy. So we covered gestational hypertension, and then we moved into preeclampsia. So you may have questions about what's superimposed preeclampsia. This just means that a client who already had existing chronic hypertension prior to pregnancy then developed a different hypertension or a different manifestation within pregnancy. So they'll have one of the following. They'll have a new onset proteinuria, they'll have a sudden and intense worsening of their chronic hypertension, or they'll start to show signs of end organ damage. So that's what superimposed preeclampsia. It essentially means just taking a patient with chronic hypertension and adding gestational or preeclampsia to them. Either form of preeclampsia can turn and potentially develop into eclampsia, which again is the presence of those tonic-clonic seizures. It's new onset, high blood pressures put the mom at a really high risk for this. Again, we give magnesium sulfate as seizure prophylaxis, and in some cases we may be unable to stop seizures, or if mom had limited prenatal care, this really puts her at a high risk of developing eclampsia. Alrighty, so now we're moving on to the very end of the spectrum. We're going to cap it off with HELLP syndrome. So the highest acuity is HELLP syndrome. HELLP is an acronym, and I'll give you a hint. It's HELLP, but I'm going to ask you guys, what does this stand for? Go ahead and let me know in the chat. What does HELLP stand for? HELLP. It's 3 separate things. It's kind of a longer one. It's a tricky one. I know OB is a very it's a specialty. Sometimes we kind of feel like it's off on its own, just like peds can be. And I know a lot of people really find it challenging, but I'm going to challenge you all to answer this question. What does HELLP, HELLP stand for in an OB setting? I see someone on TikTok got one right, hemolysis. If you don't know them all, no worries. Just let me know what you do know. Hemolysis is correct. That's what the H stands for. Elevated liver enzymes. Someone else got that. Way to go. And I see someone else saying low platelet levels. So HELP stands for hemolysis, elevated liver enzymes being the EL, and then the last LP is low platelets. So way to go, you guys. I knew you would get it. Liv got that one right. And Stella did too. So way to go, you guys. Alrighty, so HELLP syndrome is going to be at the worst, highest acuity end of the spectrum. At this point, the mom, it may even need ICU care post-delivery. This is a really, really serious condition. So essentially in HELLP, this is a diagnosis more than a condition, and it means that at this point, organs are starting to fail. We have hemolysis, we have this elevated liver enzymes being the AST or the ALT, so sorry. This is going to indicate liver damage, and we see low platelets. So signs and symptoms, epigastric pain as well as right upper quadrant pain is kind of a key hallmark sign of HELLP syndrome. Clients can become very nauseous, start to vomit. The treatment here is really the need for prompt delivery. HELLP syndrome is absolutely an indicator for quick delivery. A lot of times these clients will have to have C-sections just to get it done as quick as possible. It will require very close monitoring of blood pressure with meds to control it, and most likely also a magnesium sulfate drip. Alrighty, so that sums up our lecture content for today. You guys did so well. Way to go. You answered that HELP, which was a tough question, so I'm so proud of you. We're going to move on to our first question of the day, which is a question about preeclampsia. So the nurse is planning care for a client who is pregnant and has severe preeclampsia. Which of the following interventions should the nurse include in the client's plan of care? Select all that apply. Our options are option 1, administer labetalol. 2 is administer carboprost. 3 is check our deep tendon reflexes, those DTRs. 4 is administer magnesium sulfate. And lastly, 5 is minimize environmental stimuli. Alrighty, I'll give you a chance to go ahead and drop those answers in the chat. We're going to go ahead and jump to our next the question so they can see it. I think YouTube might be having a little trouble, but we'll get it up there for you guys. No worries. In the meantime, if you have not followed or subscribed to our social channels, go ahead and do that. We're putting out some really great content. I want to highlight our nurse life videos, which give really relevant answers to questions I think a lot of you may have. Questions about how do I survive a 12-hour shift? What do I bring to my NCLEX? How do I register? How do I make a care plan? How do I make a concept map? I think all of these are really tricky subjects, and sometimes I think the challenging part about it is it's not always easy to find resources on them, and we're trying to fill that need and meet the need and put content out there that's a little bit easier to find and answering questions that I feel like a lot of you may have. Alrighty, so let's go ahead and see what you all are saying here. All right, I see lots of 1s and 3s and 4 and 5. So people are saying all but 2. Well, you guys are correct. Way to go. Our correct answers were 1, 3, 4, and 5. So that first one, again, we have a client with severe preeclampsia. In option 1, we're administering labetalol. I told you already that this is a beta blocker. It's something that we're able to use in pregnancy. It's safe during pregnancy. It's not contraindicated. We use this to decrease and control blood pressure. In a severe preeclamptic client with a really high blood pressure, we're probably going to give this IV, but some clients, especially if they have chronic hypertension, will be switched to an oral labetalol when they become pregnant because it is pregnancy safe. Option number 2, carbapenem is also called Hemabate, and it's actually given to help that uterus contract down after delivery if we have excessive bleeding or postpartum hemorrhage. This is not going to be given in an antepartum setting. Again, remember this client is still pregnant, so we're not going to be able to give this. Option 3, check those DTRs. So true. So DTRs are going to be checked often in a preeclamptic patient. We may check the pedal, we may check the brachial ones. In a client who's on a magnesium sulfate drip, we also have a second indication to check these. So for a client that's preeclamptic with high blood pressures, we make sure they're not too brisk, which is a sign of impending seizure potentially. We also want to make sure that we're checking and seeing if they're too depressed or too low from the MAG, because we know that MAG can suppress our reflexes, which is a sign of potential magnesium toxicity. So definitely making sure we're not hyperreflexive and we're not hyporeflexive. Alrighty, and I see someone saying we can also give hydralazine. You are so correct. Hydralazine and labetalol are both used to decrease blood pressure and are safe to give during pregnancy. Option 4, administer magnesium sulfate. We already kind of brushed on this, but this is correct. Magnesium sulfate drips are given to pregnant patients to prevent seizures during preeclampsia. In severe cases, clients will be induced or delivered via C-section and actually remain on that MAG for 24 hours post-delivery. And lastly, option 5, also correct. We want to minimize environmental stimuli because this helps to prevent seizure activity. So way to go, you guys. Again, 1, 3, 4, and 5 were our correct options. All right, moving on. Question number 2. Here we're going to look at some manifestations of placental abruption. So the nurse is assessing a client with suspected placental abruption. Which of the following findings would support a diagnosis of placental abruption? Option 1 is a painless, bright red vaginal bleeding. 2 is a rigid board-like abdomen. 3 is referred shoulder pain. And 4 is uterine atony. Alrighty, go ahead and drop those answers in the chat. This is not a select all that applies, so maybe a little bit easier for you guys. We'll end on a positive note. I also want to make sure you all know about our events page. uworldnursing.com is a great home base for all of our social media efforts. It gives you a 3-week calendar of all the topics we plan on presenting, as well as an option for you to plug in your name and your email and get an email straight to your inbox every single week that lets you know what topics we're going to be presenting that week. So go ahead and check out uworldnursing.com if you have not already. And actually, if you scroll to the bottom of the page, we now offer a question of the week as well. The only place you can find and subscribe to the question of the week is on that uworldnursing.com page, so make sure you go ahead and check it out. Alrighty. I see lots of answers in the chat. I see mostly 2. But I do see a couple of ones worked in. So let's go through this. Our correct option was option number 2, that rigid board-like abdomen. So placental abruption, we spoke about a little bit at the beginning of today's lecture, and it's the separation of that placenta from the uterine wall. So symptoms will vary depending on the severity of this placental abruption. It can be partial, it can be complete. Sometimes just one of the edges starts to peel off. It can present in a lot of different ways. So in option 1, you will often see vaginal bleeding with placental abruption, but it's typically not painless. So other symptoms of placental abruption include uterine tenderness, abdominal pain. So we're going to see painful bleeding rather than painless bleeding. That's why option 1 was incorrect. Option 2, that rigid board-like abdomen, is our correct answer. This is a hallmark sign of placental abruption. I gave you guys a little wink, wink, hint, hint at the beginning of today's lecture, so let me know if you remembered that. Option 3 is referred shoulder pain, also an incorrect option. Referred shoulder pain can actually be a sign of a ruptured ectopic pregnancy. It can also be a sign of gas pain, but it's not typically equivalent with abruption. And lastly, for uterine atony, this is going to be the opposite. So uterine hypertonicity is a clinical manifestation of abruption, meaning that the uterus is very contracted, very hard. Uterine atony means a lack of tone. It's not hard, it's very boggy. So it will be the opposite of this. That's why option 4 is incorrect. But again, option number 2 was our correct option, that rigid board-like abdomen. Way to go, you guys. So you all know we are going to be back tomorrow on Wednesday at 2 and 3 p.m. Central Time with an antepartum question drill. So if you enjoyed today's antepartum content, we're going to be back tomorrow asking you questions, giving you a chance to further test your knowledge. So make sure you tune in for that on Wednesday at 2 and 3 p.m. Central Time with Nurse Jackie, and come back on Thursday, myself and Nurse Incoli at 11 a.m. and 3 p.m. Central Time. We'll be putting on a prioritization question drill. We get so many asks for more priority questions, so I hope we're meeting this need. Thank y'all so much for staying tuned. I hope you found this to be helpful. Specialties like OB can seem very different and very tricky compared to more mainstream med-surg critical care nursing. I think a lot of people are a little intimidated by it. After all, in OB, you're caring for 2 patients at once, both the maternal clients and the fetal clients. So you all really met the need. You rose to the occasion. This was challenging content, but you guys did so great. Again, join us tomorrow at 2 and 3 p.m. Central Standard Time. I hope to see you guys there.